sedative drug only. Have to monitor the patients, monitor, record your vital signs. So just remember, no Geodon and Haldol to the same patient. Now, when you have the true excited delirium, or you think this is the excited delirium, you're called by the police, this guy is totally, totally uncontrollable, big, you can hardly get near him. The cops are thinking whether they're going to tase him and make him worse. And these people suddenly die often. Probably a cardiac and or stroke kind of issue. You give them both drugs almost simultaneously. And the dose, and then, because you're only going to get IM in them, give them 10 milligrams of Versed and 10 milligrams of Haldol, or 10 milligrams of Versed and 20 milligrams of Geodon. Geodon takes, they really like Geodon because first of all it was available and it's expensive, and we always like more expensive drugs. But it's a slower onset than you would think. So if I had my choice, I would give them the Versed first, so that because it's working, and then give them 20 milligrams of Geodon, and once again, don't give Geodon and Haldol to the same patient. It's one form or the other. Okay. Clear? Okay. Pain control. This is to give you an advantage for little kids. Well, a perfect example. A child falls out of a tree, breaks his forearm. You get it in a splint. He's still whining and painful, and his mom and dad are there, and they want, and they say, give him something for pain, give him something for pain, give him something for pain. But the child screams and hollers and fights you with your IV, and not every little kid who has a broken wrist needs to have an IO in their, So we can give, this is a nice review. I like the name, it's clear as mud. Intranasally administered fentanyl has been studied as an alternative route for pain relief for children. All the studies showed similar or improved pain scores when compared with other opioids and administration methods. No severe adverse outcomes were reported. Current evidence suggests that it's safe and effective method of pain management for children in a variety of clinical settings. Another one, an intranasal dose of fentanyl at a dose of 2 micrograms per kilo provides effective analgesia for pediatric ED patients with painful orthopedic trauma within 10 minutes of administration. And we have the equipment, and it's easy to use. So you don't always have to start IVs on these little guys. Now, we know this is the general thing for fentanyl. Fentanyl is normally given in 25 to 50 microgram increments for adults, but in children, 1 to 2 micrograms per kilo may be given intranasally. If you think the child needs 2 mics, go ahead. If you think that, if you want to try to do 2 mics and then see, or 1 mic per kilo and see how it works, fine too. You can give up to 3 mics per kilo total dose. And of course, for adults, we don't give more than 200 micrograms per hour as a usual rule. Rapid injection IV may cause respiratory arrest or chest rigidity, so you give it fairly slowly. IN, I don't think there's any worry about that. You just do an IN, to do that atomize, you just squirt it. So why would you use pain control? Facilitate packaging and transport, patient exacerbation of symptoms. They do well if they start having more discomfort, or just to relieve their discomfort. You can give Versed for adults, of course, for cardiac chest pain, abdominal pain due to aortic dissection. musculoskeletal pain, burns, chest wall pain causing splinting, etc. Side effects of fentanyl, and it would be intranasal as well, although the side effects have been studied and are very, very minimal intranasally. CNS depression, hypotension, hypertension, somnolence, allergy to it, respiratory depression, nausea, and with the caveat always to avoid use of narcotics for chronic pain syndromes for transport. You don't have to give somebody who say, oh yeah, I have my back pain that I take 100 milligrams of 10 milligrams of Dilaudid every 6 hours for at home. It's worth, and I don't know what I did, but it's really bad. I need some fentanyl on the way in. No, you say, there must be some reason that you're not reacting to your pain medication. We don't want to confuse this. Bring them to the hospital. Let us sort it out. Now, people get nauseated with narcotics. I just want to make sure that everyone is clear that the dose for adults of Zofran is 8 milligrams IV single dose. We have in the past had 4 milligrams, and you can repeat, but there's no point in doing that. 8 milligrams for the adult, and then that's it. If it didn't work at 8, it's not going to work. Maybe you can give them Haldol. It's an anti. No, I take that back. You can give Versed for muscle spasms, 2 to 10 milligrams IV for muscle spasm associated with severe pain. Say a guy has done something that obviously appears to you, he's got muscle spasm, back pain, and muscle spasm. It's a good addition. Use the smaller amounts and move up. I changed the rule. You don't have to call medical control for that. Give them the 2 milligram, but give them in increments. Because remember, Versed potentiates the fentanyl. Be sure you have an adequate dose of fentanyl on board. Now, all patients should be monitored for respiratory depression. All patients getting fentanyl, getting narcotics should be monitored for respiratory depression, hypotension, cardiac rhythm, which is why you put them on a monitor. If they have a problem, treat it. Okay. Questions on nasal fentanyl and fentanyl in general? No. No, I'm not into it or into it. Okay. A couple of changes in our trauma protocols. Okay, we have a new change. Now, I don't expect that it's going to happen, that you're going to remember it right off the bat. We are taking out the terms trauma team and trauma alert. Oh, I know, but this is to become consistent with the statewide nomenclature system, and also to become consistent with communication in hospital. So, we will now ask you to say full trauma activation, that is trauma team, or modified trauma activation, which is trauma alert. We are going to have that take place by November 1st. Okay, ish, yeah. Mark says November 1st-ish. So we will let you know the exact date. We'll keep reminding you. So, and full trauma team are the box 1 and box 2 of your trauma triage tool. So nothing has changed, just those words. It's like the ACLS test. We never change the questions, only the answers. Full trauma activation is box 1, physiologic criteria, which is Glasgow Coma Scale less than 14, systolic blood pressure less than 90, or respiratory rate less than 10 or greater than 29, less than 20 in an infant under a year. So that hasn't changed. That's been your rule all along. No difference here. Same with box 2, which is full trauma activity. This is the anatomic criteria. Penetrating injuries to the head, neck, torso, extremities, proximal to the elbow and knee. So any truncal and neck penetrating injury. Head injury, but your Glasgow Coma Scale has probably got you in there already. A flail chest. 2 or more proximal long bone fractures. 2 femurs. A femur, maybe in a humerus. There's a little fudge there. Crushed, degloved, or mangled extremity. That's going to need special treatment, special trauma treatment. Amputation proximal to wrist and ankle. Pelvic fractures. Open or depressed skull fracture. And paralysis. Okay, those are the trauma team already. Just now we say full trauma activation. If you want to say trauma activation full, that's fine. Now, modified or trauma alert. Falls, adults more, see, this is the mechanism of injury criteria now. Adult falling more than 20 feet, 2 stories. Now, if you're old, you fall from ground level, that could be significant. And that's down there on the list, too. Children more than 10 feet or 2 to 3 times the height of the child. High-risk auto crash with intrusion, and you know the numbers for that. Ejection, partial or complete from the automobile. Death in the same passenger compartment. Vehicle telemetry data consistent with high risk. Has anybody got any of that ever? I don't think they publish it, yeah. Auto versus pedestrian, auto versus bicyclist, motorcycle crash, greater than 20. And then the special considerations, these are the ones. So age, older adults, risk of injury or death increases after age 55. Older adults are the only category, the only age category in the state of Washington that's having an increased mortality from trauma since the institution of the trauma system. Everyone else is decreasing. Children, obviously, it's nice to triage in the pediatric capable trauma centers. The trauma center is pediatric capable, but we don't hospitalize if the child needs to be hospitalized. So there will be some times where you're transporting and you're giving your report, and they will suggest, why don't you take this child directly to, if it's stable at this point, take it directly to Randall. Anticoagulation and bleeding disorders. Somebody's on Coumadin, somebody's on Pradaxa. It's even worse if they're on Pradaxa than some of the newer ones, because we can't reverse those. So that's one of the reasons that older people falling down from ground level falls now are high risk, high mortality, because they bang their head, get a subdural, that's that. Burns. We know where burns go. And if the burn fits the anatomic, or if the burn has concurrent anatomic and or physiologic criteria, or if it's greater than X%, we're going to take them directly to the burn center. But a patient who has other injuries, let's say they're in a car wreck and then they're burned up too, patient who has those other injuries are going to take, you're going to die of the other injury before you die of the burn injury. So if your Glasgow Coma scale is 6 from your head injury in your car wreck, even though your car exploded and burned up, and they look kind of crispy, they're going to need to have that head injury taken care of before, at the same time. And you can't go to the burn center and expect the neurosurgeon to show up at the burn center. Doesn't happen. Burn center is separate. Time-sensitive extremity injuries. That'd be a pulseless extremity from a dislocation. That will get you into the trauma system all by itself. Pregnancy greater than 20 weeks, paramedic judgment. Craig Newgard paper that we published as part of the ROC study, the trauma ROC studies, showed that the reason that most paramedics take patients to a trauma center is paramedic judgment. It's by far the number one. It's the highest percent of it. Wow, that was a bad accident. This guy really looked bad. Physiologic criteria is okay. His other stuff's okay. One thing on physiologic criteria, before I close this, I want you to understand that it's really important. Your first blood pressure. So if you have a blood pressure less than 90, I want to know that. And that patient gets entered into the trauma system as a full trauma alert. Even if the next blood pressure you take is 100, because you've done some intervention at that point. You usually got a line going, you've got a number of things. The first blood pressure really correlates with bad things that are going to happen to that patient by the time they're at the hospital or later on in the hospital stay. It does correlate with that. Now, with our change of trauma things, we're also going to change trauma scene times a little bit. A couple of interesting articles here. Looking at trauma transport times, trauma scene times, and this is McCoy's paper, and the salient part is we observed increased odds of mortality among patients with penetrating trauma if scene time was greater than 20 minutes. Another one, this is another one from Craig Newgard at the Hill, part of the ROC studies. In this North American sample, there was no association between EMS intervals and mortality among injured patients with physiologic abnormalities in the field. He couldn't find anything which would identify scene time. Another one, same authors, golden hour. Among out-of-hospital trauma patients meeting physiologic criteria for shock and traumatic brain injury, there was no association between time, scene time, and outcome. However, the subgroup of shock patients requiring early critical resources and arriving after 60 minutes to the ED had higher mortality. Now, this doesn't give you a buy off on scene time all by itself. American College of Surgeons they picked that 10-minute scene time. They picked that the way they often pick things out of a place we don't want to talk about, and it's been stuck on in our memory bank forever. The point is, it probably makes, in town, in most of Clark County, we have fairly rapid scene to hospital. And in the outlying areas, you have fairly rapid scene to hospital if you call in life flight. We want to keep the total time well under an hour. Now, in fact, if you're in the half-hour business, that's good. So But we're going to make a little bit of change in the time on scene, which will be in your orders now. Time on scene won't change. If you can't provide an airway within 2 minutes, then you should start transport, if the patient needs an airway, then transport the patient immediately unless there are extenuating circumstances. Medical scene on time is still 30 minutes or less after initial encounter. STEMI and CVA will continue to be 15 minutes or less after initial encounter. Full trauma activation, 10 minutes on scene once extrication has been accomplished. Modified trauma activation, 15 minutes or less. So with physiologic and anatomic criteria, get them out of there as quickly as possible. Now, sitting in on the Portland area committee that works on protocols, they don't think they have any scene times in Portland on traumas that are less than 10 minutes. They wanted to throw it out altogether, and the surgeons, trauma surgeons, said, no, you can't do that. It says that right here. So we're going to be evaluating that fairly closely, but we'll go for 10 minutes and 15 minutes for the trauma alert, well, what was trauma alerts, the modified. Code 99, I'll give you 30 minutes or less after initial encounter, because you usually work it at the scene. Now, we've been having really quick ROSC. So, and then, you get ROSC, you boogie, you go. One last thing, I guess, on trauma, and we'll take a little break. Penetrating neck injury. This is Journal of Injury, and it's from military experience. Data suggests that it's very unlikely that penetrating ballistic trauma, it's a nice way of saying gunshot, to the neck will result in an unstable cervical spine in survivors. You may get shot in the neck and you may die from that, but you didn't die because of unstable cervical spine. And you don't have an unstable, most of the time you just get shot in the neck and it takes out vessels and nerves and things, but it doesn't make your neck unstable. And if you put a cervical collar on someone who's shot in the neck, it may hide potential life-threatening injury that you need to evaluate. You can't see what's going on in the neck. You can't see the expanding hematoma. You can't manage the airway. So remember, patients that are appropriate for full long board immobilization are blunt trauma with altered level of consciousness, spinal pain or tenderness, neurologic complaints, anatomic spinal deformity, high injury, mechanism injury with intoxication, inability to communicate, or distracting energies. So this is your spinal immobilization procedure, which has not changed for 25 years since we wrote the first thing. If yes to any of the below, immobilize. If no, may transport without spinal immobilization. Patient mentation. Is there a decreased level of consciousness, alcohol, drug ingestion, loss of consciousness? Subjective assessment. Do they have cervical, thoracic, lumbar, spine pain? Is there numbness, tingling, burning, weakness? Objective assessment. Cervical, thoracic, or lumbar deformity or tenderness, other severe distracting injury, which is always the argument. Is a burn severe and distracting? Well, if it's a second-degree burn, probably. Is a fractured clavicle a distracting injury for the neck? Absolutely. Is a fracture any place a distracting injury? Probably, but I could argue that if they have a fractured ankle and it hurts, and no other findings, they probably can tell you accurately they don't have neck pain. So it does take a little judgment, which is why we pay you the big bucks. Is there pain with cervical range of motion? How do you test that? Well, if they say I don't have any, I feel them, they don't pain, and then they gently start to move their neck, ask them to move. I say, oh, that hurts. Well, then that's pain with movement. If there's penetrating neck injury without neurologic deficit, you can treat transport without spinal immobilization. Now, the thing we've done to keep the trauma surgeons happy as much as anything, and they're all good, but all patients who meet trauma system activation criteria, full or modified, due to blunt trauma mechanisms, will have, at the minimum, a cervical collar on. If the patient's up walking around, if the patient were, even if the patient weren't walking around and for some reason you couldn't immobilize them flat on a board because it makes them not breathe well, put them in position of comfort on the gurney, secure them to the gurney, but with a C-collar on. So if they're ambulatory at the scene, C-collar, immobilizing the gurney. Patient requiring long transport, C-collar, immobilize the gurney. Patient where a long backboard is not otherwise indicated and you're transporting the DD, just immobilize them to the gurney. Still, minimizing movement and spinal precautions is still paramount. All right, we need to take a break for a couple minutes, for about 10. Now you're going to have hospital emergency care. This actually came from a American Journal of Respiratory Critical Care Medicine. One of the researchers is, a couple of them are out of Seattle. Said EMS personnel care for a substantial increasing number of patients with severe sepsis and spend considerable time on scene and during transport. Given the emphasis on rapid diagnosis and intervention for sepsis, pre-hospital interval may represent an important opportunity for recognition and care of sepsis. Previous research has shown advanced notification of time-sensitive disease states, such as STEMIs, such as strokes, can improve outcomes and time to initiation of treatment. So, Clark County protocol for shock, general considerations. Tachycardia may be the first sign of shock. Pulse pressure often narrows prior to fall in systolic blood pressure. Changing level of consciousness, an important cue. We see that, and clue. We see that a lot, particularly in elderly persons in nursing homes, where after a couple days they call you and say, they're not their usual their usual level of consciousness. So they haven't eaten anything for the last 2 days. You walk in, you smell the familiar odor of urine, and the patient's obtunded and is probably septic. Initial intervention for sepsis per protocol is airway, oxygen, vital signs frequently, EKG, Trendelenburg if they're frankly in shock and not if they can tolerate that without interfering with aspirations. IV large bore with balanced salt solutions. For hypovolemia, assumed from sepsis or neurogenic shock, 2 liters rapidly as possible, or until systolic blood pressure is in the 90 to 110 range, neck vein distension occurs, or pulmonary valves develop. Pediatric fluid challenge for sepsis is 20 cc's per kilo, repeated up to twice. Now, this is from your general protocol for shock. If this is a head injury and shock, current studies are showing that you need to maintain a little bit more blood pressure. Usually for trauma, we like to target blood pressure somewhere in the 90 to 100, sort of a permissive hypotension. If they have head injury and shock, studies show that you need to have it a little, probably the sweet spot is 110. So target your blood pressure at 100 to 110. Maintain normal ventilation rate, remember head injury, normal ventilation rate, target your EtCO2 at 35, no less than. 35 to 40 is a good number. Now, if this is sepsis and or neurogenic shock, guy's been in a car wreck, has, you presume a complete spinal injury with neurogenic shock, not responding to fluids, or sepsis, not responding to fluids, dopamine. So 2 to 10 mics per kilo per minute. And it's the same dose for children, so or 2 to 20, they're a little bit more tolerant of that. Now, suspected abdominal aortic aneurysm, we'd like to keep your blood pressure in the same as the trauma range, 90 to 110. On the lower end, they're going to bleed more likely, or chance of rupturing if you increase their pressure. Now, cardiogenic or DKA, etc., type of shock, fluid challenge, 2 to 300 cc's over 5 to 10 minutes, repeating as needed unless they're developing RALs. I would kind of prefer an epinephrine drip if you have cardiogenic shock. You could use a dopamine drip or an epinephrine drip. Rapid transport. Now, for septic shock. Now, these are the cues that we try to think of sepsis and septic shock. Known or suspected infection. So these are the definition of SIRS. Temperature, known or suspected infection with 2 or more of the following: either hyperthermic, temperature greater than 38, which is 100.4, or less than 36, which is 96.8. A lot of these older persons in the urosepsis from the nursing home will end up being actually hypothermic. Respiratory rate greater than 20 per minute. Heart rate greater than 90 per minute. And EtCO2 less than 25. Obviously, they're breathing rapidly. They're getting rid of CO2. So if you have suspected infection, suspected sepsis with any of those, any 2 of those, notify the facility, septic shock alert or sepsis alert, however you want to characterize that. Okay. Clear? Okay. Stroke and CVA. Now, we're not going to go into the full stroke scale. This is an interesting article, which is actually at this time almost 10 years old, but people are now starting to pay attention to it. It's a simple 3-item stroke scale. I'm going to make it even simpler so you don't have to make a stroke scale. But basically, it looked at the prediction of usually the worst kind of strokes and the ones that can be dealt with by intervention. And intervention has now been shown with 6 studies that intervention, neurosurgical and/or neurointerventional radiological intervention, removing the clot with a number of clot extracting devices, has been shown to significantly improve outcome from severe stroke of the middle cerebral artery. And the things that predict middle cerebral artery occlusion, the finding of stroke, are profound aphasia, significant paralysis to the point that they are unable to raise an extremity off the bed, right arm, right leg, or both, and comatose. So, with those three findings, if you had a choice of hospitals to go to, with any of those three findings, you would make the choice that a person should go to where we could get neurointervention done, because those are the likely ones that are going to need neurointervention. So we're changing the protocol just a wee bit. So your protocol for stroke and CVA is primary survey, fast assessment, determine onset of symptoms, last time known, normal. Protect and maintain airway, patient in the lateral position on the paralyzed side. If they're paralyzed, if they're not paralyzed, you don't need to put them on the lateral position. Airway control as needed, suction as needed, high flow oxygen. If you suspect intracranial bleed, maintain normal ventilation rates, target ETCO2 at, it says 30, it should be 35. RSI is needed. Titrate oxygen to the lowest level required to achieve SpO2 of 94 to 99. You don't want to go over 99. Don't want to go to 100%. In fact, so you should really target it about 95, 96. Too much oxygen is bad for injured brain, too. Maintain ETCO2. Oh, there it says now. Got two different things, right? ETCO2 at 35 to 40. This one has to be changed. We'll go back and get that. If the patient is conscious, reassure them. Patient may understand everything, even though they appear confused or comatose, they may understand. They're just not able, they're not able to speak, to articulate that. Consider other causes of abnormal mental status, means hypoglycemia, drugs. Consider and evaluate for predisposing conditions for stroke, hypertension, dysrhythmias, particularly